All right, keep going. Yeah, I want to keep hearing about macular degeneration before I introduce you. This is really interesting.
Yeah, sure. So, just to kind of highlight, we were talking about collateral blood supplies forming for the heart, and you have, underlying coronary artery disease. The blood vessels, the main vessels, are blocked off, so your body makes new blood vessels. And new angiogenesis is the term, and that's basically your new supplier. And sometimes that process can become abnormal. It's not regulated. There's actually some pathologies associated with that. And macular degeneration is actually one example where you lose your central vision, basically at the macula of the eye. It's the spot where you can focus the most at the back of the retina, your clearest vision. So once that starts to go, we don't know why it happens. There's a genetic component, but the mechanism that they've studied so far is related to VEGF. That's a protein called vascular endothelial growth factor. And what you essentially have developing is abnormal blood vessels that are now supplying other parts of the eye, and that takes away from the supply of the macula. That's the proposed mechanism that they've found so far. It's not, final, but the treatments they're making, like these monoclonal antibodies, it's like immunotherapy. You probably see a lot of ads for them. They're targeting that. So they're trying to make antibodies specific to that protein. And yeah, that's pretty much it.
Is there, well, like with that, does that usually happen in isolation, or are there predisposing risk factors for macular degeneration and something happening with respect to the arterioles? Can that happen somewhere else in the body, such as within the lungs or within the brain, causing such as a pulmonary embolism or a stroke?
So um, when it comes to new blood vessels forming, um, in the lungs, we don't really see that too often. In the brain, we don't see so much as new blood vessels forming, but we see congenital genetic issues where the walls of certain people's vessels are so weak they're prone to developing aneurysms, these outpocketings that can then bleed and cause hemorrhagic stroke. But no, at least not immediately. I can't think of anything else off the top of my head, but there are other cancers that are associated with high levels of VEGF. It's basically just a protein that signals the local areas to promote one type of growth as opposed to another. The cancer cells need you know larger blood supply. They're more metabolically active. That's basically the extent of that. But I can definitely like look into that because I'm sure there are a lot of things with abnormal angiogenesis out there.
Because it's an interesting component, and I know it's something that we'd wanted to talk about today, which was with respect to research side, clinical side, and the performance side,
Yeah,
was one of the big positive physiological adaptations to endurance training, more specifically like the zone 2 aerobic training, is increases in mitochondrial density and capillary density. So
yeah,
we think about like increased capillarization as an increase in your ability to have gas exchange, which is wonderful. So when you're like jogging and someone's like, how are you talking and jogging at the same time? It's pretty much the answer. Like your heart is becoming so efficient with respect to their stroke volume, increased capillarization, increased mitochondrial density. But I've never thought about it on that sense from clinical perspectives of like, oh, if your coronary arteries or one of those arteries is blocked, you'll make increases in arterioles or maybe capillaries in some other part of the body to use a crutch for that. And that's just a predisposing risk factor for a heart attack. I'd never thought about it that way, but it's almost like there's different things. I had no idea.
yeah, yeah. So that's we see that quite often, and it just goes to show that like cellular regulation and genetics from like your actual genetic code to epigenetics, all this stuff can lead to such a variation depending on the environment that you see this phenomena take place in. So at the muscular level, increased capillary density, all that is a positive adaptation, whereas some other form of that could be pathologic somewhere caused by your genes or vascular injuries, inhalants exposure, smoking, chemicals, all that stuff. Um, yeah, yeah, it's crazy how one thing can be beneficial and the other thing in another aspect it can be the cause of so much harm.
Waleed right in the middle of his conversation because I was like, this is brilliant. I don't want anyone to miss this. This is um, today's guest is an old friend from high school, college, and then present day. His name is Dr. Waleed Azam. He is a brilliant, hardworking, and honest physician. As I said, my friend, someone I've always enjoyed hanging out with and always looked up to. Um, we used to like watch hours of countless, videos and Ronnie Coleman videos, and we hit the gym in high school, hit the gym in college, and that was always really fun. And I remember getting the half off Papa John's pizza.
Was it Papa John's or Pizza Hut or something? I don't. It was something like that.
And we would just eat
Man,
as much pizza as we could. And now it's like,
yeah,
okay, maybe we should chill out with that. But
we should not do that.
it's funny because fast forward to today, and we haven't caught up in a couple years, so I'm really excited for this conversation. Waleed's in his third year of internal medicine residency training. He's building on a
That's
strong
right.
academic foundation in cell biology, and his current research focuses on predictive markers of mortality and acute cholangitis, which I'm excited to hear all about. And his scientific interests span body recomposition, lengthen biased resistance training, and metabolic syndrome. And personally, what I admire is his drive. His goal as a doctor is simple but powerful, and is to learn as much as possible so he can share, teach, and treat as many people as he can. So, Dr. Waleed Azam, thanks for coming on to Simple Science and having a chat with me today.
Of course, Mike. Thank you so much for having me. It's honestly an honor to be able to speak with you. Watch everything you've accomplished as well, and to be able to speak on it at a platform like this, share this with the audience. I think it's an excellent opportunity, and it's also. I just want to say one thing. I think a lot of my success, I think I also owe to you because before I went into undergrad, I didn't really have that much direction, but what I did have was someone telling me kind of what to expect and what to prepare for, and I think that really helped me hit the ground running, and I'll never forget that. So thank you for that, Mike. And yeah, I think we have a lot to talk about today. A lot of exciting stuff. I'm by no means an expert, but I'd like to share what I can. I think I've listened to a lot of good speakers on different topics, including yourself. And yeah, I'm excited to get into it. So without further ado,
Yeah, let's get on into this. And it's funny too because one of the moments that I think about from college, like more than ever, is when we took our physics exams, our physics finals next to each other
yeah,
in Tillett Hall, and it was like a 3 hour exam. And I kept like looking to see if like you were done yet because our last names are so similar. And I was like, that was such a hard
yeah,
final, man. But
dude, it was
I
it was
remember
tough.
afterwards I texted my dad, and my dad's like, "How was the final?" I was like, "I don't know," but I sat next to Waleed, so it was all good. Um, but it's funny to see how things work. So I was interested, like, I don't think I've ever asked you this question, but from as long as I can remember, you wanted to be a doctor. Where did that come from?
So um, initially, it started as I was someone who didn't really have too much direction in terms of what I wanted to do in my life. And of course, my parents, South Asian parents, family members, they're always like, you become doctor or you become oil, right? Like, it's like some variation of that. I mean, that's like a pardon my French. But yeah, so you got this subconscious idea floating around. People are telling you. I also don't have much direction, and I, eventually got into fitness and health, and that kind of segued into me wanting to learn more, not just about metabolism and the body, but kind of everything related to biology and the human body. And then I also found that I feel like being a doctor, you kind of trust them, you kind of carry like their opinion with some weight, and I feel like that was a good way for me to kind of share this knowledge as well while also growing and at the same time, helping people because more often than not, you'll encounter somebody either on their last day or last few days of life here or, having their worst day. that they've had to date, and to be able to be kind of like the shining light for somebody, that's a feeling that I don't think a lot of professions can really give you. So I would say it's a component of like personal interest, um, kind of kind of basically enjoying the journey of getting there rather than knowing what my clear destination is, and then eventually finding out what I like to do and why I like to do it. So I would say, in simple terms, that's pretty much why I chose to pursue medicine.
And did that, like when we were in college, did you have a pretty good idea of where you wanted to take all those science courses? Did you ever think about teaching? Did you ever think about research? Did you ever think about PT, OT, anything else besides like being a medical doctor and like being patient or client focused, like patient focused, whatever the term is?
Yeah, so I did think about it, and one of the things that I really like that really I needed was I like to know things from like the ground up, from like the base level. In order for me to learn and to be able to associate that and to actually take it in and be able to effectively use it, I need to learn things from the ground up. And I feel like medicine was the field that could offer me that. And I feel like once I can learn from, the very basic sciences and build on top of that, I decided that's what it is for me. Just having knowledge on a lot of different things from the ground up. Now, with PT, OT, I did think about that, but more so as like something I wanted to learn about on the side. Something that was like more of a hobby for me, in the sense that I'm interested in that. I have an osteopathic background, so we do perform some things known as osteopathic manipulative therapy. A lot of those principles are adopted from PT and chiropractic. I thought about those things, and in the end, I just decided to go with medicine, just on the fact that let me start with this, see where it goes. I've already, I know who I am. I know what I need to know in order to succeed. If I'm constantly asking more questions, it's never going to end. So that's kind of where that started.
Is that one of those things that excites you about medicine is just the constant pursuit of the next greatest medicine, which can help people. It can help health span, it can help lifespan, and we can even administer this in a safer way. Or we may not have to administer medicine. We can also go the lifestyle approach. Like, do you have that in your daily job and even just kind of going around your head while you're like driving home?
Yeah, absolutely. Because the field, by design, by nature, is always evolving. I need something that keeps me on my toes, just to, stay interested, but also like stay humble. You have to keep up to date with things. Like, this is not something that you can take lightly. People's lives are at stake as well. Um, in terms of thinking about daily lifestyle changes, I absolutely think about that. I think preventative medicine, and I think we'll get into that, is probably one of the most underrated fields of medicine. And part of it could be, the business aspect of medicine. There's not as much money to be made from prevention as there's treatment. Part of it could be we don't promote lifestyles the way we should in an effective manner. It's a very multifaceted problem. I like to think that I do what I can to address the lifestyle while also addressing, your acute needs. Um, but at some point, like, you can only do so much, and it's there's too many things involved with everything going right. Your patients need to be motivated themselves to make the lifestyle changes. But that's definitely something that's always there in the forefront of my mind, and even something I look for in terms of new research. It's not just about the new medication, but it's like, what's the best lifestyle change that's best for you, or something you can adopt.
So who's the, I guess the, before we get into like your approach, who's the, do you have an avatar patient that you would see day to day, or is everyone just like a little bit different?
So right now, because I'm in my third year of training, my last year of training, uh, we do 4 weeks we do on the inpatient side. So that's anywhere from medical floors, the ED, critical care units. And then 1 week, so every fifth week, we do in the clinic, outpatient. So every now and then you see somebody that you've seen before, but right now there's no patients of my own or under my own license. That'll happen once you know, if I decide to make my own group, my own practice, then they'll come under me. Or once I'm working at a hospital, then I'll have those patients under me.
Is that an exciting challenge, or are you also maybe looking forward to specializing in something? I don't know, because there's so many different types of doctors, and there's like residency and fellowship.
Yeah,
Like one of my other good friends is doing I think a fellowship down in one of the cancer centers in Tampa, and I feel like he's just in school forever. And he's like, yeah, no, I'm loving it, so I'm just going to keep learning and helping people. I'm like, so what is it that you do?
yeah. So fellowship is basically additional training on top of residency. It can range anywhere from 1 to 3 years, and it's usually focused on one organ or organ system or one branch of medicine, whether it's very procedure heavy or whether it's something that only focuses on one thing. That's what it is. And it sounds like if he's at the cancer center, uh, hematology and oncology. So that's a subspecialty of internal medicine. Certain specialties in medicine, you have to do 3 years of internal medicine in order to get to, like cardiology, gastroenterology, pulmonary critical care, and then hematology, oncology. Surgeries are separate. Radiology, where you read the imaging, that's all separate. Dermatology, that's all separate. But these are the ones where you need to do internal medicine and then additional on top of that. And yeah, that's essentially the study of new chemotherapies, radiation, new cancer treatments, and yeah, that's a very exciting field, and definitely requires a lot of training because also carries risk with it. Um, a lot of the chemotherapy patients, they tend to be on the sicker side, a lot of side effects of chemotherapy. So I would say, honestly, 3 years is not even enough to learn everything you would need to know. It's likely a few years of being and attending and working on your own where most people start to feel comfortable. And so to answer your question, as of now, I'm not planning to do any more training. I just want to work, um, see my patients, come home, live a balanced life. And then in the future, if I want to do more training, we'll cross that bridge when we get there.
And your current, I guess, passions or research interests are in cholangitis. Is that like the main thing?
Yeah, so right now I'm on a research project. So initially I was interested in gastroenterology, but I decided I want to put that on hold for a bit, kind of, just stick with internal medicine for now. That project is looking at, so basically what we're going to do is we're going to look at ICU level admitted patients requiring critical levels of care. And what we're going to do is we're going to see what other factors, so the specific one we're looking at is the red blood cell distribution width to albumin ratio. So these are things you see on your blood work. Uh, whether a specific ratio of that presentation, because these are markers of your blood count and variation of your red blood cells, as well as your hydration and fluid status. What ratio, if any, can be used as a prognostic marker for mortality? So we're going to look at all the data. We're going to see, controlling for a bunch of variables, what comes out to being significant and not. And then we're going to see if we can use that data uh, to compare it to this ratio and see if patients who are at one side of the spectrum had worse outcomes as opposed to the other side of the spectrum.
And is that something that's going to be before the issue at hand, or does that ratio get messed up because of whatever they're presenting with in the hospital?
Yeah, so that's all on admission. So what we're looking at is just the initial presentation and to see, people who scored on this side, are they more likely to make it versus people who scored less, or more. So it's all going to be taken on initial presentation.
And that's it's almost like the way that I kind of think about this. If this makes sense, and please let me know, like if I'm like on the right sort of wavelength here, is that like there was some point in time where people did not know that increases in LDL cholesterol was a marker for future cardiovascular events. And then people found that out and go, oh, okay, so if you have a high LDL or a total cholesterol score over 200, you should probably lower that because you could get a heart attack or a stroke down the road. Is this sort of what you're trying to do? Is you're trying to find a ratio and say, like, could that be a little bit of a red flag on blood work of, ooh, if you have this sort of ratio with, what was it, like albumin and red blood cells, if that could then be like a
Yeah.
flagged marker of like, ooh, we should intervene here.
So to answer your question, that would be the thought. But at this stage, it's more of just like kind of for the ego in a sense. Like this is just something that you can add to your repertoire of numbers to look at for prognostication because the treatment is still going to be the same. Depending on how sick you are, you treat the patient and their symptoms. You don't go based on the lab marker. So in certain cases, you do. Like it depends on the situation, why they're there. It can help you kind of guide your judgment. Like, your hemoglobin level, if somebody is bleeding out, they need blood, that's the answer. But in this case, um, patients who come in like this, they're treated as a whole. So it'll be of little value just to base it on that. It's kind of something just we're doing to see if it'll have any value in further grading and further indices that they come out with to kind of stratify the presentation like we do with cardiovascular disease risk. There's different score calculations that you can develop. And a lot of these, the ones that are, researched based on large scale studies and evaluated with meta-analyses, they're then published and promoted as the guidelines. So once they're promoted as guidelines, this is stuff we are taught as physicians. I don't think this will make it there, but it might make it into a calculator, like an MD calc. There is one already. This might offer another approach to it or another thing to look at. So small scale in that aspect.
But I mean, talk about a contribution to science.
Yeah, for the great, I like to think of it as something for the greater good. I've done my fair share of like cookie cutter, copy paste research. Like it's the same thing over and over. So this one, hopefully, we're in the middle of a data collection. Hopefully, it turns out well.
Is that one of those things where like you ask your patients like, hey, we're looking for this, would you sign an informed consent? And just like
So
you take it in like a blood vial with all their other lab values and you just kind of you send it off to like a lab core somewhere.
so um, the way we're doing it because it's with the hospital, so they're going to provide us with data from previous patients that met this criteria. We went through the whole approvals process with the IRB, and we're just going to use data that's already there. No patient identifiers or anything like that. And so the consent is kind of implied once we got the approval from the review board.
Who's is it through a specific university or like the hospital system? Or I've never, because like I do that at the university level. I've never done it within a hospital. I think it's brilliant though.
Yeah.
You have
So
all these
so the
like all
hosp
these health data. You just need like HIPAA compliance and IRB to
yeah
say okay, and it's like, oh, here's 1,000 patients worth of data. Like you can't just get a research team at a university to be like, hey, we need 1,000 people. It's like, oh, here you go. It's like, no, there's
yeah. So
limitations.
that's one of the benefits. That's one of the benefits of I guess healthcare research. The pool of observable data, observational analyses that you can draw mostly correlational conclusions from. That's pretty widely available. On the large scale, you also have some NHS materials that on the national level you can also access similarly. Um, but it's this wouldn't be like clinical trials with control groups or anything like that. This would just be additional stuff to contribute to the major idea, and then everything kind of together. Uh, Once that's reviewed, that's what leads to like policy and guideline changes. Yeah.
Is there any big backing for doing this?
So
Do you
you
have
can,
research support? I don't know, because I mean you're a doctor in his residency and then you're also doing research. It seems like a huge extra weight on you, which is awesome. You're providing for science, but is there that backing? Like I really have no idea, because as a researcher, like that's your job. But
yeah. So in this context, resident level research, unless you're at a major academic institution like your Ivy League institutions, or like the Mayo Clinic or like hospital systems that are affiliated with these big names, your research is likely not going to go anywhere, and you're doing it just to kind of show interest and commitment in the fields for your next step, which would be a fellowship application. So the research funding that we get is usually, a couple thousand uh, around there just for a project, a stipend if you need to attend a conference, if your work gets selected for that. But that's about it. The the more like if you want to go further down the research route, then you need to go to a major academic institution or find some other form of funding. But it's good, like I would say, introductory level work. It definitely refines your ability to review stats and you know contribute to the greater science good, as you said.
It's almost like, and like this was something I was interested to speak with you about, and I try and ask as many clinicians as possible like this exact same question is, how do you make sense of the yearly gap or 10-year gap between everything that's going on with scientific research and then what's practiced in a clinical setting? And like my example is that when I was 18 years old and I was just like any other 18-year-old kid in the gym trying to get huge, and I started taking creatine, the doctor asked me, he goes, "Are you taking any vitamins and supplements?" I said, "The only vitamin and or supplement I take is creatine monohydrate." And he was like, "Why?" And I was like, "Well, there's all this research to suggest that it can increase skeletal muscle strength, skeletal muscle power, and potentially decrease your risks of getting neurodegenerative diseases down the road." And I figured, why not? It's very inexpensive. It can't hurt. I have Parkinson's in my family. I want to get stronger. Why not? I've been doing it for about a year or two. And he goes, "No, stop. Basis for doing that, it's not going to help you. It can only hurt you." And that was just one doctor. But every time I teach a sports nutrition class, I ask the same questions. And they're like, "Oh, my mom doesn't want me to take it. My dad doesn't want me to take it. My doctors want me to take it."
Yeah.
So how do you bridge that gap with you being a clinician while you also liking the performance piece and you also have your hand in research?
So that goes back to getting the right information. Unfortunately, in medical school, in medicine, that's not something we're taught. Science related to exercise, physiology, in terms of optimizing health, that's not really something that is taught, let alone supplemental, like supplement studies. Now, creatine is 100% supported. It's the most researched supplement out there. It absolutely works. Take it. Take up to 10 grams if your GI system will allow you monohydrate. It's still shown to be beneficial. I mean, the studies are coming out are quite incredible. That doctor just did not know because it wasn't in his scope of practice for the most part. All he knew was maybe something that he heard from down the line. And the way I bridge the gap is if I see it or if I hear it, I'll try to fix it. But the reason for that is that's something that I kind of went in and wanted to learn about. It's not something that we are taught as physicians, unfortunately. Nutrition, like health sciences, exercise, things of that nature, that's not in the curriculum, unfortunately.
So where does, I don't know, like, and I really appreciate the complete honesty there, not only in like your honest answer, but also you saying, "Hey, like I would want to be an honest and discerning and curious doctor for myself and do my own research," which is great. Um, do you see that there continues to be some of that disconnect, maybe in current doctors and then like doctors who are aging a bit, in that maybe they are resistant to diving into the literature, or is like diving into the literature maybe with respect to pharmacology, is that obviously necessary and needed, or what's that kind of look like in your setting?
So I think if you are going to tell somebody what to do with the intent that, they're going to likely listen to you and follow what you say, I think that, as a physician and as a person, you should do right by both yourself and them to look into the truth to an extent where you can speak on it honestly. And if, let's say, your patient asks you something and you don't know the answer, you don't feel comfortable, you can say, "Hey, I haven't really looked at it, and I can find out for you, or I can send you to someone who I think would have a better answer." I think that's what the approach should be. So in any encounter that I have, it'll be some type of response in that range. But you shouldn't just say blanket no without knowing why. Now, whether it's age related or whether it's related to, old school physician versus new school, I can't really say. I personally know examples of physicians on the older side that keep up to date with things, and physicians who just graduated who like this is just a job for me in and out, and I don't care outside of that. So it's tough to say. I try to do my part where I can. I try to speak to the patients when I can. You have to balance everything from you know listening to them, telling them the treatment plan, while also telling them about lifestyle. um, it's kind of like a patient specific thing. Unfortunately, it can't be universal, at least not yet. There's just not enough time in the room with them. And you also don't know if they're going to listen or not. But yeah, definitely, I think that physicians should take the time to learn about it. They don't always.
Do you think that more medical schools would benefit their students if they would have them take even one or two additional electives with regard for exercise, sleep and stress reduction, nutrition, like that whole thing?
I think it absolutely would be beneficial. Um, but I can tell you from experience, the amount of stuff we cram in the first 2 years, and it's only growing. Where would the space be? Like I started school. We started the third week of July, medical school, and it goes all the way until maybe the third week of May. And then you have maybe 6 weeks off, and then after that, your first 2 years, when they're done, you just go on to rotations. There's no more summer or anything like that. I think that they should incorporate it. Um, in terms of how and when they will, that I don't know. That's a larger problem, but I think it would definitely be beneficial. I think that there there should be some level of knowledge, universal, like uniform knowledge, that doctors should have regarding exercise and nutrition. I think so.
Yeah, I can't even imagine like how how much information that you need to know. I've just heard it's a fire hose of information, and from people who got like 4.0s in college, like I can't imagine doing that. I did not get a 4.0. And then for those people to like go wide eyed of like, yeah, med school is really difficult. I'm like, holy cow, man, that must have been way more difficult than undergrad.
But yeah, definitely, it's just, but it's difficult in the sense that the volume of information and the amount of time you have to learn it is a lot. That's what the big step up is.
Are you
But
oh, you go on.
no, no, go ahead.
I was
Go
gonna say
ahead.
like with respect to like do you ever have patients quoting like Dr. Google or Dr. AI?
I absolutely do. And so the best thing I do with that is I ask them, what is your understanding of this topic and why do you think that? And then I tell them what I know. I tell them if I know about the topic, I'll tell them what the research says. If I don't know, or if it sounds blatantly wrong, then I'll either tell them I can find out for you, or I don't think you should follow this advice, but I can find out more for you after. Dr. Google is a real thing. I try to, like, the more harmful the information, I try to dispel it right away.
Yeah.
But if it's not something super harmful, I try not to blow up anyone's ego in like a short minute encounter. Uh, so yeah, that's basically the approach to that. The thing with the Google and all those things is um, they put any possible presentation that's associated with any condition. So if your one symptom is cough, like a cough can be associated from anything from cancer to like acid reflux and anything in between. And so, you read that, you think it could be this versus that, but what you don't see are the nuances and the variations. Like, okay, well, this also presents with X, Y, and Z. And so the probability of you having this is very unlikely. Like as physicians, our job is to navigate probability. There's certain things that we have guidelines for, certain things that we have documented research for, algorithms and protocols for. If something comes like this is what you do next, from inpatient to cardiac arrest to just outpatient routine follow-ups on when you should get your colonoscopies. The rest of the stuff, and I would say maybe close to 70% of it, we don't have research on. We don't have controlled trials on. We don't have guidelines on. Um, so it's partially anecdotal and just been best practices in the field of medicine. And then your best judgment. We are just navigators of probability. And, should something happen, should you make a mistake, the way they evaluate it is with a third party physician who also weighs in and says, did they use the best intention and best available evidence based things that we have on this topic to inflict harm or not. And so that's basically what I've come to understand is our role. That's what I've seen. That's what I've gathered from different physicians. Unless you're, surgery or something invasive, the role of the medicine doctor is to kind of navigate the probability and recognize things and pay attention to detail. So that's kind of why I'm in it.
I love that, navigating probability.
Yeah.
Because it's funny, like I went to like a neurologist appointment like a year or two ago. I had a heat stroke, and like everything was just really off and funky for like 6 months. And I saw a cardiologist, neurologist, got a bunch of blood work. Like everything was just off. And went to this neurology office, and I was just sitting there, just in the like waiting in the patient room, and this lady was talking to the lady at the front desk, looking at schedule, and she was like going off about how the doctor was dumb and he had no brain cells and she was smarter than he was and she wanted a new doctor and all this different stuff. And I was like, at a certain point, like, doctors probably 99% or even more have, the best intention, go through medical school, take the Hippocratic Oath, and they really care for the well-being of their patients, themselves, probably their family and their friends. But yeah, it's like nothing's guaranteed. So you can hear countless examples of people going in for a routine this or that, and it turns into a full-blown surgery. It's like, well, sometimes there's complications, sometimes unforeseen things happen. um, but that's, I don't know, it's almost like I want to like acknowledge all of you as saying like, hey, like I know a lot of you are doing your best, so thank you. Because like I can't imagine being on the opposite side of that, of like, can you believe what this doctor did, they did this and this. It's like, well, you weren't the one doing the surgery, or you weren't the one administering the drugs, or you weren't the one doing the 24-hour shift and looking over 20 different patients who weren't yours or whatever.
No, absolutely. I think that definitely taking some time to like ground yourself, see something from either the provider or the patient's perspective can definitely help. I think there's a fine line between um, fatigue and your performance declining, or you miss something because of something else going on, versus like blatantly not caring about something. And unfortunately, we don't get to analyze things like that until something happens. And there's like a retrospective evaluation of that. But if nothing comes of it, nothing happens, there's no conflict, then we kind of just go on continuing the same way we are. So you mentioned LDL earlier,
Yeah.
right? I think some of the stuff that we had talked about was like cardiovascular disease risk. I actually wanted to ask you about something as well. So
Well, now I'm gonna have to keep up
have
with
you?
you. Usually I'm the one
So,
asking the questions, but I'm happy to talk with an actual doctor about this. So
well, so I mean, we use LDL like as our main marker. It's incorporated into our uh, guidelines and calculators to determine risk on whether we recommend somebody to start taking a statin or a lipid lowering agent or not. But I also wanted to talk to you about ApoB. Have you heard of ApoB?
I have, but I don't think I could put together a more compelling conversation like on my opinions.
Okay. So
I
the
understand
the
like the
things we
lipoproteins. I understand how they work, but not specifically like ApoB. For example, if you wanna keep going, I'm more than happy to do this.
Yeah, so I think one of the questions you had asked me was about what field of medicine should there be kind of more research in, like to the point where we can get more guidelines from, right? Like what's a topic in medicine that's has value but it hasn't made it to the guidelines yet. So I would say there's two major ones. One, which we'll kind of just hint at, is basically the way I think of things is micronutrients, macronutrients, and then other, right? And so you need your macros, thermodynamics, physics, all that, energy balance. You need your micros because we have enzymes where biological systems, um, two identical twins may not even have the same metabolism. So you incorporate for that. The micronutrients are important. And then the third party is your toxins, your hormone dysregulators, microplastics in the water. I think that's a subject and a topic. We're just now realizing on a large scale that red 40, like dyes, are bad for you. Who thought? Um, so I think that's one topic that definitely needs research. And then I also wanted to talk about lipid research and cardiovascular disease, which brings me to ApoB. So for the longest time, we thought that LDL is a bad cholesterol. It's the lipoprotein. It's known as the carrier, and most of the research does show that high high serum levels of LDL does increase your risk of cardiovascular disease. More so in the context of metabolic syndrome. So from a medical perspective, things we look at for metabolic syndrome, like your insulin resistance, the central adiposity, central obesities, things of that nature. We look at your hemoglobin A1C. That's a marker for your average blood sugar over 3 months. And again, that also has limitations. If you have a baseline issue with hemoglobin, different anemias, you have to kind of take it with a grain of salt. And you need further evaluation for your diabetic profile. But that's the other thing. Diabetes goes in the metabolic syndrome. Your lipid panel, mainly your fasted triglycerides, because that's your actual lipids. That's the part of the lipid that's going into that blood vessel that just experienced that vascular inflammatory insult, whether it's from free radicals or high blood pressure. And now you got this cascade of vascular repair going. That's what kind of goes in and is the building block. The rest of the stuff, like the HDL, the LDL, those are your carrier proteins. And for the longest time, we go based on LDL. LDL is bad cholesterol. It's more the marker for you're requiring more of this unit, and this unit we've seen deposits peripherally in your vasculature. And one thing we didn't really look at is the actual component of the LDL. So the ApoB lipoprotein is basically another marker for LDL because it gives you an idea of the number of LDL particles. Because when you check LDL on a regular lipid panel, it doesn't really account for small, dense particles. So someone might have a crazy high LDL, someone might have a very low LDL, and they might have the same number of lipoproteins. And that's why apoprotein B is the marker, because it'll give you a quantifiable number. The small and dense particles should be treated just as much as someone with, larger particles of LDL, because this person with the smaller particles is going to have an LDL that looks normal. So that's why you have to look at everything as a whole in terms of metabolic syndrome. And I think that's something that in medicine, if it hasn't already, it should start taking the place of like LDL.
Is that something that is going to be found on a typical metabolic panel, or would a doctor specifically look for ApoB in addition to HDL to LDL cholesterol, total LDL, total HDL, etc.?
So it's not found on a traditional lipid panel. Your traditional lipid panel, you just have your HDL, LDL, total cholesterol, and triglycerides. And the ApoB, part of it is it's not fully promoted by guidelines yet, but there's a lot of researchers who, are not physicians, but are in this field of lipid research. And it's looking very promising. It just hasn't made it to guidelines yet. A lot of physicians don't even know about it. I actually stumbled upon it not too long ago, and then I went down the rabbit hole just learning about that. The other thing that also is a big thing is insurance and reimbursement. It's a more expensive test. It's more specialized. Certain labs don't run it. Your insurance won't cover it because it's not deemed medically necessary. So those are some barriers, unfortunately. But I hope that it's something we use more because it's been more promising for cardiovascular disease risk.
Oh, so now like I don't feel as like uncomfortable because like my dissertation was largely on lipid metabolism and specifically triglyceride responses in the postprandial period. So I can talk to that, but like I've definitely heard of like ApoB, but I'm not going to give a lecture on it. But it's promising and it's awesome to hear that you're like, hey, like we have a pretty good idea, as you said, that it's a marker of the concentration of lipoproteins, which can let us know, does this need to be addressed with like a statin, exercise, diet
Hmm.
modification? And we can use that as a marker, but it's just not there yet, which is awesome. So, I mean, I love that. It's almost like I always love going back and like watching old movies and TV shows and people just smoking cigarettes next to kids. And we're like,
Yeah,
oh my gosh, that's so bad. But like back then, it's like, yeah, smoke your cigarettes. But now it's like cigarettes are bad. So we're going to tax them like crazy. It's like, good, do that. So hopefully
yeah,
the next
at
5 to
least.
10 or 20 years, we'll see like ApoB is like, oh, like my ApoB is high. Okay. So start exercising and get on a statin.
Yeah, yeah, if you need it. I mean, statin medications, they're not just for the cholesterol lowering part. They've shown a lot of promise with the anti-inflammatory component, and they're most effective as prevention. They do help with, already formed plaques. They keep them from getting bigger, but in the larger scheme of things, they're best if they're caught early. So yeah, I think that would be very beneficial.
I never really thought about um, statins in that light before, but I'm happy that one big thing right now, which is hitting the streets, is people talking about antioxidants and anti-inflammatories. And oxidation, it's like you go back to Chem 1, it's like oxidation reduction reactions. And it's like, okay, you're losing electrons. It's bad if you're getting oxidized. Like we know that can be really harmful, as is chronic low grade inflammation. So if you're asking the
Yeah,
question of like, why does someone get cardiovascular disease? It's like the common starting point might be obesity or being overweight, which typically goes along with like what elevated hemoglobin A1C. Maybe you have some dyslipidemia, and that can lead to inflammation over 20, 30, 40 years, which can lead to like a huge event of like
that's
cardiometabolic
exactly
disease.
right.
And I'm happy that like my younger students right now are like, yeah, I eat healthy fats because they're like anti-inflammatory. They don't know what they're saying, but I'm happy they're eating
Hmm.
healthy fats.
They're eating something. Yeah, they're doing something right. They just don't know why. Yeah.
So where do you think I know, I like in your professional opinion, I know there's going to be a million nuanced answers. If someone presents and they're overweight, high blood pressure, and resistant to exercise, which is like probably most people in the United States, what's like a couple of maybe easy but very high return on investment things that you can tell them to start doing, which maybe have a very low barrier to entry, but offer huge rewards? Like, what are a couple things that you would tell them in your professional opinion? You could do this, this, and this, and it's going to really pay off.
Absolutely. So the first thing I would tell them is to resistance train. Okay, in resistance train in the sense that something that engages your muscles, that's going to add active metabolic tissue, right? So the way I think of it with obesity and these lifestyle modifications is you need to increase your caloric bank and your budget of calories. You need to increase that so you can sustain it, so that you can keep the weight off and still be happy. And so the best way would be to add lean tissue. The other thing I would say is, your heart is the most important muscle, and the benefits of cardiovascular exercise are absolutely, like, you can't deny them. So what I would recommend them is 3 days of resistance training, 45 minutes, train to failure, 2 sets per, I would say, per muscle. Maybe do 2 to 3 exercises. And smaller muscles, you maybe only need one exercise. 2, maybe 3 max sets to failure, and that's it. Train hard, train better than last time for your next session, and get your zone twos in, right? The easy jog, the steps, something that you can maintain, because whatever you're going to maintain and continue with is going to be the most effective. Then in terms of diet, um, I would tell them, again, this is also all contingent upon then, mentally feeling ready. If they have some other type of emotional stressors going on, that has to be addressed if that's a barrier. But I'm saying, like, if this is a patient who is willing to change, this is what I would tell them. From a dietary perspective, I would say you got to figure out in some way, shape, or form approximately how many calories you're maintaining at. And then we start with that number. And every few weeks, you're going to reevaluate that number, because this is a dynamic thing. Because I don't know what your numbers are. I don't know what your needs are. We're going to find that out together. And I would say, for the most part, 90%, 80%, stick to whole foods. Try to limit the processed stuff, the hyperpalatable things. Aim for more satiating foods. So your fruits, your vegetables, lean proteins. You can have some fat protein if you want every now and then. That's fine. Healthy fats, of course. Give them a list, talk them through. Recipes would be the next step. First, you got to show me, you're dedicated to this. And yeah, I think with those three things, you are more than 90% of the way there. The biggest issue, the biggest hurdle is consistency, staying with it, and knowing when to cut yourself some slack, having that self-awareness. It's okay to fall off the wagon for a little bit. Don't feel sad. It's not too late. But you also, like, you can't be lazy. You can't just take the easy way out. You have to be self-aware. So with those things addressed, that's how I would start them off. Not too much, but, like, that's a good starting point.
And that what got me the most on that was you said, like, with resistance training around 3 days per week, and you're like, yeah, just go to failure, but you're like, oh, yeah, only 2 sets per muscle group is completely fine. And I'd probably follow that up with like a compound lift, even on like a machine of like a leg press or a lat pull down or a bench press. And it's like
Mm-hmm.
that's what they tell us to do. Because there's the idea of like, how do I become the biggest, strongest, and most efficient of 10, 20 working sets per week? But to be healthy, a couple sets per week, taken, at least sufficiently close to failure within 3 reps, and
Yeah,
add in
yeah,
the
exactly.
exercise component, because as you said, the heart's the most important muscle in the body. And if you're shortchanging your cardio, you're just shortchanging your life.
Yeah,
And it's like,
that's
why
exactly
would you
right.
want to cheat your life by cheating your heart? Because you don't want to do a little jog or something. But yeah, and that's the thing, is that's the consistency component. And it's funny because there's so many clickbaity YouTube videos and podcasts of like the single best ab exercise and the single best
Yeah,
diet and the single best this, single best that. And it's like the best. And it's like, I love how cliche it is, but how true it is the best exercise routine is the one that you can stick with,
exactly.
forever. You can sub out some chest exercises here and there, or sub out a form of cardio here and there. But it's like, if you exercise 3 to 5 days per week, or even 7 days per week, and stay moderately
Hmm.
active, you'll probably live to a pretty healthy old age, barring some
Exactly.
pre-existing condition. If there's a meter out there with your name on it, there's not much you can do about it. But
There's not much anybody could do about that one.
no, man, I love that. So how do you has your perspective and practices changed from, I remember in high school when we took pre-calc together, you were bulking on 4,000 calories a day, which is like the most 17-year-old high school bodybuilding kid
Yeah.
thing to
Oh my
do.
God.
How has
That's
that changed over the past, I don't know, 13 years or whatever?
so. I would say with new information, I've changed my approach. I think the one thing I did well was that I tried everything. I tried the bulks, then the cut. I tried the 5 sets of 10 high volume. I tried the, okay, let me keep like 5 reps in the tank, and deadlift, and who's got the strongest lower back when strength training was popular. And what I've found now is that if you're looking to gain muscle or just improve your lean body composition, um, you definitely do not need to bulk and then cut. Like, that's just very outdated. You'll get fatter than you absolutely need to. The biggest thing I would say is I've incorporated, maintaining a higher protein diet, anywhere between, like, a gram per pound of body weight. That's more than enough. You could get away with like, gram per lean pound, lean body mass, and or zero point 0.8, something along those lines. And then again, if you find that protein keeps you fuller, or your body has a better response to it, digestion, how you feel throughout the day, then you can go more. Stay hydrated, get checked regularly. It's pretty safe. And then I would say that I've basically realized that as long as you train pretty hard, you give your muscles, the stimulus to maintain and grow, you keep your deficit, very slight, maybe around the 300 to 400 range max. And you don't do it just through diet, you do it through exercise as well. So you're not just maxing out, your body's dietary capabilities until your metabolism and BMR all drop. Um, if you keep that, then I think that's the best way to change your body. Muscle gain happens very slowly outside of the beginner years, and it's not worth it to go crazy. Every now and then you want a cheat day, that's fine, or you're gonna go and just chill out for a little bit, that's absolutely fine. But now it's a much more nuanced, smaller step approach, and taking the whole thing into consideration.
Yeah, I love that. I love like the generality but specificity of that. Do you
Yeah.
ever almost, and I find myself in this way too, where you know what can be optimal? Do you ever kind of get really excited with the optimal stuff, but it might not be practical and time efficient? So therefore, you go with what is like science backed and necessary to be healthy. Like, do you ever have to bridge these two gaps?
So I would say all the time. Which gap and what thing I incorporate, it depends on how practical it is for me, though. So I like to learn about everything that's the most optimal. Training within a rep or two of true failure, and then hitting that same muscle, within a 4 day period or 5 day period, so you still get it within twice a week. Uh, Gauging progress like that, like that's what I've found is what best works for me. What I found, some research also says, like, Jeff Nippard, a bunch of these guys I also follow. Milo Wolf, I don't know if you've heard of
Yeah.
him. Mike Israetel.
Corey, he's the goat. Yeah. He's in a
Yeah,
league of his own with this stuff, man.
yeah. I mean, outside like the personal stuff or whatever that goes on, based on like their research, I try to take whatever I can, and whatever I can. Like if I have more time one week, I'll go work out more. I'll go lift more. But I try not to neglect my cardio, because that's also very important. And so the most optimal for me now is what's the best balance that I can continue, and that's how I kind of reconcile that. Like whatever optimal component I can incorporate, I do. Whatever I can't, I won't. So like I can't go lift 5 days a week and also do like 5 days of meaningful cardio plus balanced life and all that stuff, plus get like 200 grams of protein from like chicken breast. Like that's just not going to happen. If I was single, if I was 10 years younger and I knew all this stuff, then sure, I would push the gas. But those are just aren't my goals anymore.
Yeah, it's funny because like I know what someone needs to do to qualify for the Boston Marathon, or maybe get a huge PR with weightlifting or with a bodybuilding goal, or get like and like some pro card in bodybuilding. And like I think about it all the time. Like when I'm running and I get the runner's high, or I'm like lifting and I'm like feeling like a good pump that day, I'm like, oh, I'm gonna ramp up my cardio. I'm gonna do 2 days, this. And I'm like, wait. If I can't adequately recover from this right this second, or like today,
Exactly.
and if that hinders me from coming back tomorrow, the next day, and the next day, I don't do it. So it's funny, like I've almost religiously stuck with like zone 2 cardio for the past like few years, even though I do it every
Hmm.
single day for 1 or 2 hours. That's what works for me personally. And I'm on a 5 day lifting split, which again works for me personally. But anytime that I try and do way too much volume, or way too many intervals, or way too much like pure strength training, I burn myself out, I get sick, might get an injury, and then I get demotivated. So I'm like, oh, let me stop just shy of like crankiness, I feel like I need to fall on the floor. Let me stop right before that, make sure I can recover to come back again tomorrow. And I feel like if more people did that, which is easier said than done, I mean, the country and the world as a whole would be so much happier and more relaxed and just healthier. Because it's like we're almost trying to like weigh out that uneven distribution of like how healthy is like the US, and it's like not very healthy, but you have like all the people who are obsessed, but this huge camp of people who do absolutely nothing. And I'm like,
Yeah,
how do we take you guys and shift this over this way so everyone just starts taking walks, everyone lifts once or
yeah.
twice a week, and wow, like everyone for the most part is living longer. This is great.
So unfortunately, happy mediums are not attractive. They can't be sold.
Yeah.
We have we have people who are who've given up before they even thought about it, and then we have people who don't feel like they had a workout unless they've struggled and gone too hard. And if I'm not going 100% every day, then I'm a failure. And your workout is only as good as your recovery and how good you are the next time. Because much like your brain learning something new, your muscles also need to learn something new and adapt. They need time. Your central nervous system needs time. Your immune system needs time to recover. All these things are are an acute inflammatory process for the body. Like exercise induced damage. It's just like any other inflammatory process initially in the response it evokes, the cortisol, the shifts in hormones. Now, obviously, the after effects and the beneficial stuff comes afterwards. It's not like the same if you were to get like a chemical exposure or inactivity, but this needs time and nuance, and people, you just can't sell them on it. That's the unfortunate reality.
It's funny, like on that, I've had I feel like I've been like on and off personal training ever since I came to college. And it's like, okay, it's like
Mm-hmm.
now I'm on like year 12 or 13 or something. And starting out at like big box gyms, I remember like my bosses would be like, Mike, you're not the best personal trainer, but everyone loves you because I was just like a good talker. But all my clients
Mm-hmm.
got results because I did everything science based. And it was like, we would do 2 sets, then we'd graduate up to 3 sets, then we graduate up to 4 sets in a very like linear periodization model. And we manipulate like training frequency, how many days per week. We'd manipulate intensity with the rep schemes, but we'd keep like 1 or 2 biceps exercises, 1 or 2 tricep, 1 or 2 chest, 1 or 2 back, because it works. You go in the different planes of motion. And all the other trainers who were doing these crazy like gauntlet style hit classes with
Yeah,
like the
circuits and all
50-year-old
that.
moms
Yeah,
who couldn't touch their toes and they were just trying to be healthy, but they're like, oh, but this coach said to do this. And they'd be like, Mike, you're not a good personal trainer. I'm like, they're all getting results in a healthy manner. And it's
yeah,
and it's tough
yeah,
because you can't sell something like boring that works. And I'm happy that
yeah.
now we're kind of shifting that mentality to more science-based things. And when you brought up Jeff Nippard, I think he does it in the most science-backed, honest, but also like aesthetically pleasing way of doing it, because like all his videos are just
He's
they're cool. Like the
he's got
graphics
an
are
insane
sick and I'm
editor.
like, nice
Yeah,
man, you
he's got it down. Yeah. Yeah, no, he's great. His like especially with the tier lists, like
yeah.
tier of exercises for different groups, all that. That's great. Can't tell you how many times I've seen the guy over at LA Fitness just wasting my man's time throwing the medicine ball up and down. Like, come on, man. And like I know you got to get paid, but at some point you have to tell him the truth. Like what this is actually doing is just making you good at medicine ball throwing and burning some calories. That's all that is. It's not something you're going to take away with you unless you genuinely enjoy that, which is fine. That's your activity, but you have to be honest with people, you
You're
know?
just doing the medicine ball throw. Yeah, it's funny because that came up yesterday in conversation. We go to an LA Fitness around here just because it's like the I guess the most air conditioned of all the other gyms down here. And
Yeah.
my girlfriend said to me, she was like, did you see that personal trainer who was on like the machine next to us? Because her and I were doing like a traditional leg day. We did like a couple compounds, did a couple isolations. We're just ping ponging back and forth. And the trainer was just like doing double and triple drop sets with this man who looked like he was in his 60s, central adiposity. was just kind of huffing and puffing. He was just kind of like, yeah, 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 to get him to do like a triple drop set of like leg extensions. And I was
God,
like, there is no point in this man who is obese, probably has high blood pressure, probably has dyslipidemia, to be trying to do a triple drop set on like leg extensions. I'm like, why does he need like the most
yeah,
jacked quads in the world, man? Like,
also it's a good way to get him to burn out early, and then he's not going to want to come back. So yeah, definitely not something I'd recommend.
it's funny too because um, I just watched a video recently on like kind of debunking or kind of taking a couple stabs at P90X. And
Hmm.
you and I both started with P90X, and that was just like the most incredible, fun like introduction to fitness that we had. But now looking back, it's pretty good like cardiovascular wise, and good if you're trying
Yeah,
to increase your proprioceptive and kinesthetic senses to understand where you are in space with like your balance. But in general, it's not going to get you like increases in muscular hypertrophy or muscular strength.
no, it's not.
But it's like
Yeah.
that's an honest effort. And now we've come to this point 15, 20 years later to the point where we say, okay, this is what's optimal, but there's still a lot of unanswered questions, which is beautiful.
No, I think it served its purpose, which was to get people going, and they did it in a cool, creative way. Like watching those videos, that was so motivational,
Yeah, Tony Orton.
and
Look
yeah,
at
and
X.
it just gets you going, and yeah, no, I think that's the most important thing. Like we have to keep an open mind as to what's coming out, what's recommended, what's better versus not, and I think that's the only way to make it um, through life in general, and especially with these professions. You got to keep up with it. You have to keep an open mind, and then you have to be able to convey that message to someone in a meaningful way, in a way that they can understand and appreciate. Because what's the point if you can't do that? You just keep it to yourself then.
Yeah. Do you feel that on that topic, do you feel that you have a bit of a duty or responsibility to be the conduit between the professionals, the doctors, the clinicians, and the lay public? Of like, do you feel the need to play both sides of the spectrum of like, this is everything that I practice and I help people with, but I also really want to help people out to let them know in general, do X, Y, and Z, and there's going to be a high return on investment?
Yeah, absolutely. So my approach is if I can tell you both what I'm supposed to tell you and what everybody tells you, like the research and the guidelines, and then I can tell you what I found that actually works, stuff that, we're not taught as medicine, but this is something that both I've looked into the research of and it's very promising. I also would promote this. If someone were telling me this, how would I want them to tell me, explain it to me, motivate me? I try to think of those to the best of my ability, and there's only so much you can, cater to a specific person. But yeah, I focus on the delivery of the message, and yeah, like oftentimes I do find myself having to bridge the gap between what the doctors are saying and what people are actually interpreting, and you need someone to kind of explain it in layman's terms. And I think that it's the duty of every physician that they should be doing that, because otherwise, if you're not, people aren't going to be that likely to follow you, and then how are you going to get your message across? So
And do you think that people are more inclined to seek out your advice and take your advice who are maybe not in your inner circle? Because to your inner circle, you're the family member, you're the friend, you're the son, you're the brother, whomever, but maybe outside people who don't know you personally do very much trust your opinion and they'll take that advice.
I think they do because of two reasons. So one is I try to explain to them what's going on in a way they can understand, whether it's an analogy or whether it's kind of just explaining to them the mechanism of how things kind of happen with just the right amount of detail. Usually I try to keep it minimal, and if they ask more questions, I tell them this and that. Um, and then I think that the other thing would be honesty, like tell them this is how much I know, this is what I can offer you. I think that would be like the best way that that I can get that across.
No, I love that. That's so good. Is there it's like moving forwards. What would you like to maybe accomplish given the time, given the resources? If you could really like accomplish anything, like some humongous goal, would you like to end cancer? Like what would be like the first, what would be in your lineup of three things that you would love to do within your career, given the resources, the time?
So in my career, I would down the line, if you know if everything works out, I'd like to have my own practice, like my own clinic, where I can not only practice, you know, traditional medicine, adult medicine, but also offer different services and you know, kind of as like an add-on, not necessarily from a medical standpoint, but just as you know, whether it's nutrition or lifestyle coaching to some degree, incorporate that into my medical practice somehow. Um, so that's kind of up in the air. That's like a long-term goal. Other things would be I do want to run a marathon.
I
I
did
want to
not see
finish
that
one.
one coming.
Yeah, so I don't know. I've been running a lot, and like I just keep telling myself if I can like get really good at zone two, you know, maybe I can zone two my way throughout the whole thing. So no, but getting my cardio up, start with, you know, maybe a 10 or 10K. I think that's like 6 miles, right? So I think I can
You
do
could do that in
those.
under an hour.
Yeah, yeah, um, yeah, half and then eventually a full marathon. That's something I want to do. And the last thing would just be a good role model, especially for my daughter. You know, be there for her, be there for my wife, my family. Those are my three main goals.
I love that. It's like open up a my own practice where I can help a lot of people, run a marathon, and be like the best dad and husband I could be. I love that.
Yeah, that's where I'm at, man. Old. Although I still every now and then I still watch, you know, some like stand-ups or some of those old comedians. You know that like what was that movie we used to watch? 21 Jump Street,
Oh, that we used to watch The Dictator with Sacha
The
Baron Cohen.
Dictator. Yeah.
Used to watch that all the time.
Oh,
These are
yeah.
these are
Lots.
these are like the important things though, and it's funny because
Yeah.
I don't know. I A part of me gets frustrated when my mom always used to tell me, and like she still does tell me, my brother still tells me, be realistic, and I hate that. But you have to be. And like before we started recording, we had a brief conversation about how life's been and what's going on and what you're grateful for and everything. And your priorities shift. I remember like
They
being
do.
in high school and college, and I think high school is not a great proxy for like being an adult because hopefully you do mature after the age of like 15, 16. But even when you're 21, 25, you can still have these huge dreams and you can accomplish them, but it's going to be at a cost of something. And that's what I
Exactly.
realized was like when I was running a bulk of my marathons and my ultras and I was clicking them off nearly every weekend, people they don't see the rebound. Like they don't see the dehydration, they don't see the heat strokes, they don't see like the
Yeah.
chafing and the GI issues, they don't see the body weight issues, they don't see the training and the money and the time and the exhaustion and the extra caffeine involved. And it's like, you don't know what that was
Exactly.
like. It's like these medals look cool, but now I have something called balance, which is the most beautiful
Hmm.
thing in the world. I have a loving family and friends and a job and so many friends I can't even count them. It's the most beautiful thing. So I love
Exactly,
that
dude.
you're
And
doing the clinic
that's
thing and then the dad thing and then your own goal thing. I'm like, hey, that's it. That's amazing.
yeah. Yeah. I mean, at this point, there's nothing else I could ask for. You know, thankfully, um, you know, life has always been great in that sense. Um, so I think it's, you know, both my duty, your duty, and anyone's duty to pay it forward, take what you can, grow from it, and, you know, pay it forward to your neighbor.
Absolutely. Waleed,
Yeah,
this was so much fun. Thank you for
this was a pleasure,
coming
dude.
on. And
Thank you so much. Yeah,
I think that I mean it's like the value that you have added and you can continue to add, especially in your career with all of your patients and your families, is amazing. And it's my dad always said to me, Michael, who's coming over to the house later today, And I'd start listing off all these names, and he goes, "Oh, that Waleed guy, is he the one with the $1 million smile?" And I'm like, "Yeah, that's him." And I never told you that, but my dad always says, "Is he the one with the $1 million smile?" I'm like, "Yeah, but he can back it up because
Wow,
he's a sweetheart." And you've always backed it up. So this has been amazing.
I
Thank you
appreciate
for
that.
coming on and being my friend and
Tell
everything. And
tell him I said hello, and tell him I appreciate that.
I will, yeah, for sure.
Yeah. All
Alrighty.
right, man. We'll be in touch. Okay.
All right.
All
Thank
right.
you.
Take care, boss.